Let's talk about GERD. Okay. So there is a GER, just GER. And then there's a GERD, okay, where you actually have a disease. So anybody can have GERD, right? You ever eaten too much and you go, right? Because you have a sphincter right here. What's it called? Lower esophageal sphincter, also called the cardiac sphincter, okay? And your stomach is only meant to have like so much in it. You overfill it, and that sphincter is gonna try to release some of it, right? Okay, that can give you GERD, okay? But if you have GERD, then that means you actually have a floppy sphincter. Doesn't matter how much you eat, it just pops open whenever it wants to, right? When you swallow, it's supposed to open. Okay, it's supposed to open, and then once you get the food down, it closes and keeps the food in, right? But in GERD, it's like, yes? Okay, yeah, write that down. All right. So they have a floppy sphincter, okay? So now the acid in your food is going to come into the, you think that feels nice? No, burns like all holy hell. Now what happens when you keep burning the inside of your esophagus? It's going to cause inflammation, right? Okay, what happens with chronic inflammation? You're at risk of esophageal cancer. Oh, no. Okay, so let's talk about things that would cause you to get a floppy sphincter. That is one big one, because that baby done shoved right up in here, and it's gonna and make that sphincter just keep open all the time. Okay, you with? Obesity. Why would obesity be a risk factor? The diet, they may be eating too much at one meal. That is true. Okay, and if you chronically do that, you're gonna ruin your sphincter. That's gross too. All right, what's a hiatal hernia? Oh, really?
Yeah.
Oh.
Isn't it like it's a different kind of ulcer? It's like
It's
a
not an ulcer.
bulge. But
It is a bulge, but it's not an ulcer. What's the bulge? Where else can you get hernias? You can get a hiatal hernia. You can get a inguinal hernia, like right where the panty line is. Yes. Uh-huh. Yeah, I don't know. Okay, so what is it? What's the bulge?
It's like intestine.
It's intestines coming through your muscle layer. Yeah,
I knew someone who had one.
I bet you did. Yeah.
No, it was on his testicles.
Oh, you probably shouldn't. Yeah. Probably shouldn't have just gone around poking someone's testicles. Yeah. All right. So it is part of the intestines. There's a hole in your muscle or weakness in your muscle, and it will protrude through. That's why you can poke it back in. Right? Okay. So hiatal hernia is way up here. So if part of your intestines is poking through, that's going to push up on all of your stomach contents, causing, yes? Okay. Too much alcohol. That is a known irritant. It's going to irritate your sphincter. This is a gross day. Sorry, I'm saying nasty things. It could be if you're drinking a lot, you're throwing up. But chronic alcoholics don't usually puke, right? They can hold their liquor. Yeah, right into the stomach. Yeah. Smoking is a known gastric irritant. Y'all know that. It can irritate all the way down, right? Because even when you're smoking, like it does go in your trachea, right, and go into your lungs, but of course some of it is going to go into your esophagus and into your stomach, right? Stress. Why would stress be a risk factor for GERD? You better get this one right. You're increasing your cortisol on function number 11. And cortisol is increased acid production. Good, good. Gastroparesis is a risk factor. What does paresis mean? To not paralyze, but weakness or stop your stomach. Who gets gastroparesis? Some autoimmune do. What's more common? There are two hormones in your pancreas that stop your stomach, amylin and somatostatin. Diabetes, they get diabetic gastroparesis because their pancreas overproduces those hormones, causing their stomach to just stop. Okay. If you have a connective tissue disorder, like what? Like what? Does anyone know one connective tissue disorder? No? Yes, y'all do. Y'all had genetics, haven't you? Oh, just kidding. So you don't know anything. Okay. Do you know scleroderma? Marfan's? Ehlers-Danlos syndrome? No, nothing. Cool. All right. So if you have a connective tissue disorder, then your connective tissue doesn't do what it's supposed to, aka your sphincter. What did you say?
Lou Gehrig's.
Oh, Lou Gehrig's is neuromuscular, but not necessarily connective. Connective tissue is like something that is the stretchy part.
They're
Yes,
like 24 and what, 42.
that is true. Eating large fatty meals, that just wears out your sphincter. You got it. All right. So signs and symptoms. How do we know they have GERD? What does it look like? Y'all know people with GERD. I probably had GERD at some point. So heartburn, regurgitation. They have nausea, vomiting. It's going to keep going up here, so they may be hoarse, right? Because it's so irritated up in their esophagus. Yeah. They can have chest pain. They may say they have chest pain. That's a really crappy thing in the ER. We get super pissed off because when they come in and they say they have chest pain, you say you have chest pain and you're getting an immediate cardiac workup. We got 60 minutes to get you into cardiac cath. We did all this work, right? We started 2 IVs and we did all these cardiac labs and we did all of this stuff, EKG, blah, 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 to find out you ate too many wings. Yeah, now we just mad. Okay, so heartburn, nausea, vomiting, laryngitis. They may have that hoarse kind of voice, right? They may have chest pain, but we don't call it angina. What is angina? But what is it? It's cardiac related chest pain. So we don't call it angina. Okay. We just say they have chest pain. Retrosternal chest pain. What does retro mean? Behind the sternum. Okay. So it's going to be, that's where your stomach is. Yes. Okay. Dysphagia with a G. What's dysphagia with a G? Difficulty swallowing. So maybe kind of painful to swallow or hard to swallow. Regurgitation. They feel like there's a lump in their throat. Where's the pain? Epigastric. This is a stomach disease. They have halitosis. What is halitosis? Yeah. Okay. When do you think it's the worst? Don't look favor. When you lay down. So it's going to be worse at nighttime or anytime you're laying down. Yeah. And then right after meals because you've done overfilled your stomach. Okay. Let's talk about the complications. Now that it's burning your stomach lining, burning your esophagus, what are some things you think could happen? Do not look at your paper. Okay, so cancer, esophageal cancer is a big one. It could cause ulcers over time, absolutely. It can cause something called Barrett's esophagus. What is that? It's not, it's a precancer, right? It's a precancer because it's so burned. Huh? Yeah, dysplasia, which is basically like if we don't fix this now, it will become cancerous because isn't dysplasia like a hop, skip, and a jump it away from. Thank you. I couldn't get it out. Thank you so much. Okay. Strictures of the esophagus. What's a stricture? Pinch. It's a pinch. So because there's so much inflammation, your esophagus can get very narrow. Now, how easy is it to get your food down? Not easy. So food's going to get, oh no, no. And then I think in your class they call it throat cancer. There is no throat cancer. It's esophageal cancer, just so you know. Cool. But I added throat on there anyway, just because I thought they might throw it on a test and y'all be like, well, she didn't say throat. She said esophageal. All right. So GERD can lead to Barrett's esophagus, which can then lead to esophageal cancer. Do we understand? How do you want to diagnose? You want to look at it? I need to see your sphincter. Huh? All right. So we can do an endoscopy. But I can't really watch the sphincter open up, right? You could do a barium swallow now, but you would have to catch them during active GERD, which is sometimes difficult to do, right? So what we'll do is we drop something called a pH probe, okay? It goes in like an NG tube. It goes all the way down into the stomach, but it has a computer inside of it, okay? And you send them home with it, okay? And then after 24 hours, you bring them back and you download all their info on the computer, and it will tell you at what level they reflux to and how many times. So I would go and look at yours and be like, oh, yes, you refluxed yesterday 214 times up to the level of the mid-esophagus. Isn't that wild? We live in quite a world, don't we? All right, that's a 24-hour pH probe. Do you understand? 24 hours, yes. Because it's hard to catch it in GERD. She's right, you can do a barium swallow. But in a barium swallow, they would have to be like refluxing at that time, and they don't reflux all the time, right? All right, so guess what our treatment is? The big three. Number 1, PPIs, which end in prozole. Number 2, H2RAs, which end in tadine. And number 3, antacids. Yes. Okay. If this patient is puking all the time, what's your other risk? Well, all those things are true, but I did like this. They can get teeth erosion because that acid sits on your teeth, right? We see the same thing in bulimia, right? When patients throw up repeatedly, they start to get erosion of the teeth, okay? Now, these patients can also present and they look like asthma patients. Why would they come in with wheezing and trouble breathing? they've aspirated it. So they often get misdiagnosed as asthma. And we're like, what's the first line treatment for asthma? Here's an inhaler. That's stupid, right? Okay, so if you have a patient that you diagnose with asthma and they're not responding to any asthma treatment, then you really need to think about, yeah, you missed a GERD. Okay? All right. This is where you're going to live, breathe, right here by the GERD diet. You will have a select other apply. But sure, you give them a glucocorticoid. Yeah, you're like, oh, here, just fix your asthma. And then, oh, sorry about your GERD. Your stomach's bleeding now. All right, so here's the GERD diet. We already know most of these, right? Caffeine, citrus, tomato, chocolate, any fast food, fried foods, high-fat food, peppermint, soda, because it's a little acidic. It's very carbonated and very acidic, okay? Any high-fat dairy, okay? And dairy is a known gastric irritant. Smoking and alcohol, y'all should know these, yes? All right, eat small, frequent meals. There will not be any point in time where you will not pick that on an exam. Do you think there's ever a time you're going to tell a patient, eat one big, giant, nasty meal? No. So small, frequent meals, okay? Now, how do you want them to sit? Upright, because the more laid back they are, the more they're going to reflux because that sphincter is going to open. Okay, so you need to keep the head of the bed elevated. Now, most people aren't in the hospital for GERD. Come on now. Yes, they're at home. So how do you keep their head of the bed elevated at home? You can use pillows, but on an exam, they'll tell you to put blocks or bricks or books underneath the head of the bed, like underneath the actual like legs of your bed. I know it's very stupid, but it's on the test. Thank you so much. Okay. Maintain a BMI of less than 25 because the more overweight you are, the more at risk of GERD you are. No alcohol. They'll either say do not eat after 5, which I'm sorry, what? Okay. Or don't eat at least 4 hours before you go to bed. Okay. This is assuming that these are elderly people, I guess, because who eats at 4:30 for their dinner at Luby's and then goes to bed? Okay. Make sure that you're exercising regularly. Do not wear tight clothing like skinny jeans or yoga pants. Okay. And then put the head of the bed at home on blocks. I can't, it's stupid. Okay. Do we understand GERD?
Yes.